Ma'am, please start in 3, 2, 1. Please start. We are live.
Yeah. Namaskar and good evening, everyone. I welcome you all on the second day of Onco-Vigyan, the theme for the conference, Science and AI in Oncology. With immense pleasure, I would like to invite Dr. Mukesh Bansal, who is Senior Consultant Medical Oncology and Hematology at Alchemist Hospital, Panchkula, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Namaskar, good evening everyone. I welcome you all in day 2 of second edition of our oncology conference. The theme for this year is Onco-Vigyan, Science and AI in Oncology. Uh, I expect like yesterday we will have great academic discussion focusing on the latest ESCO updates in various cancers, various systems. And again, we have kept the agenda of day 2 also to be very short and crisp. I request everyone, all the speakers to stick to the time limits. Again, I welcome you all. So for the first session, I invite Dr. Sachin Gupta, sir. Sir needs no introduction. Sir is Director Medical Oncology and Hemato-Oncology at Max Super Specialty Hospital, Mohali. Sir will be speaking on the role of Opdita in upper GI malignancies. Welcome, sir. Good evening. Over to you, sir.
Thank you, Dr. Mukesh. You have organized a very wonderful conference.
Just a minute.
Section. I welcome Dr. Prabhat Ganju, Assistant Professor, Homi Baba Cancer Hospital and Research Center, Mohali. He will be speaking on the stridazine, the new standard of care in first line unresectable hepatocellular carcinoma. Over to you, Dr. Prabhat.
Thank you, Dr. Mukesh, for inviting me. Without much ado, I'll start presenting. Is my screen visible?
No, it's not. Yeah, it's visible now.
Okay. So I'll be talking about the STRIDE regimen and its role as the new standard of care in hepatocellular carcinoma. So we know that liver cancer has become one of the more common malignancies in India, especially. It's the 7th most common cancer and the 4th most frequent cause of cancer-related death globally. Just a minute. Sorry. So if we see HCC in India, it is the 11th most common cancer type and the 8th most common for cancer-related deaths. And in men, it is the 2nd most common cause of cancer deaths. If we see the incidence and deaths, it's actually quite discouraging. The number of deaths is very close to the incidence. And there is a male preponderance with 4:1 ratio. And the incidence of HCC in cirrhotics in India is only around 1.6% per year. So we have around 50% of patients of HCC they present in the advanced stage, BCLC C and D. If we see the pathogenesis of HCC, we know that inflammation and immune dysregulation, they contribute highly to the development of HCC. The etiology can be either chronic infection like HBV or HCC, can be metabolic syndrome leading to non-alcoholic steatohepatitis, or chronic alcohol abuse leading to alcoholic steatohepatitis. All these things lead to cell death, cellular stress, and this leads to inflammation where there is deregulated liver immune network. So the immune suppression and exhaustion happens, missing tumor surveillance, and leads to proliferation and pre-oncogenic transition. This leads to fibrosis, cirrhosis, and development of HCC. So there are multiple mechanisms how there is evasion from the immune system. We have been known to find out that overexpression of CTLA4 and PDL1 is a big factor, and inhibition of the antigen presentation is another factor. If you look at the risk factors and pathogenesis, we know that a viral hepatitis plays a big role. Alcohol, tobacco, aflatoxin. We also know that metabolic causes like non-alcoholic steatohepatitis, obesity, diabetes, they also lead to development of HCC. And there are other contributing factors like geography, male sex, and autoimmune hepatitis. So this leads to development of cirrhosis and finally HCC. So metabolic causes have now become a big factor in the development of HCC. We are having a larger proportion of patients who have metabolic causes related, non-alcoholic or non-viral related cirrhosis. If we look at this article that showed that the most common etiology of HCC was non-alcoholic fatty liver disease, followed by viral hepatitis B and C, and then alcoholic. So the most important risk factor in India as of now seems to be NAFLD. And if we look at now the management of the advanced unresectable HCC, going by the updated BCLC algorithm, if we look at BCLC-C, then we have options, first-line options of atezolizumab, and what I'll be talking about, the STRIDE regimen, durva tremelimumab, and otherwise, if not feasible, then the TKIs or even single agent durvalumab. And second line therapies, we have other targeted therapy, regorafenib, cabozantinib, ramucirumab. If we look at the evolution of the systemic treatment in advanced and unresectable HCC, we have gone from sorafenib, regorafenib, and lenvatinib to now in 2020 with the IM-BRAVE trial, the atezo-bev combination. Also, there was role of ipi-nivo combination. And now in 2022, the STRIDE regimen, tremelimumab plus durvalumab. So the SHARP and REFLECT study showed that sorafenib and lenvatinib were approved in first-line treatment of unresectable HCC, where they offered a median OS of around 10.7 months and 13.6 months respectively. But these are modest improvements in OS, and they were associated with considerable side effects. We know hypertension, loose stools, proteinuria is a big problem in these patients. So we had the development of immune checkpoint inhibitor and anti-VEGF combination. So here the IM-BRAVE study, 150 study, it showed that atezo plus bev, when compared to sorafenib as standard of care, they studied co-primary endpoints of overall survival and PFS with certain stratifications. They showed that there was an improvement in the median OS and median PFS in the unresectable HCC, where there was significant separation of curves in both OS and PFS. Median OS was 19.2 months versus 13.4 months, around a 6 months benefit. If we look at the subgroups, then here almost all subgroups showed that atezo-bev was a better suited treatment. And if we look at the OS in the viral subgroup, there is a significant difference where atezo-bev has been shown to be better, the HBV associated and HCV associated HCCs. Whereas if you look at the non-viral hepatocellular carcinoma, the atezo-bev combination does not do much better than the sorafenib. So if you look at safety and toxicity, the most commonly reported adverse events with atezo-bev were hypertension and proteinuria. We also know that using BEV in patients with CLD, portal hypertension, esophageal varices is a big risk because of the risk of bleeding. So this combination of a dual IO came in where they used a dual immune checkpoint inhibitor with an anti-CTLA4 and an anti-PD-L1 or a PD-1 drug. Here, the CTLA4 acts by it in the lymph nodes and increases the number of T-reactive cells, and the anti-PD-L1 agent acts in the tumor microenvironment and prevents the T cell inhibition, the deregulation. This enhances synergistic anti-tumor activity. So the combination of durva and tremelimumab increase the anti-tumor activity by reversing the T cell exhaustion and allowing T cell activation respectively. So the CTLA4 blocked by tremelimumab allows T cell activation, and durvalumab is a PD-L1 inhibitor, which reverses the T cell exhaustion. So there is a concept that, a single priming dose of tremelimumab with durvalumab could improve immune-mediated clinical activity in these HCC patients and could minimize toxicity. So the concept behind this is that the high dose of tremelimumab will cause an initial burst of peripheral T cells in these patients. There, from the lymph nodes, the suppressive T cell signaling by the CTLA4 is inhibited, and there is an initial burst. That initial burst has been shown to be very effective in having a good immune effect. So this has been used in non-small cell lung cancer and in melanoma, where you use ipilimumab nivolumab combination, and that there is an initial proliferative burst of T cells, which is not repeated at subsequent doses. So there was initially a phase 2 study that evaluated tremelimumab plus minus durvalumab, including the STRIDE regimen. And then this was further taken up to show that the STRIDE combination showed the highest efficacy compared with the other durvalumab and tremelimumab combinations and monotherapies. So the median OS with the STRIDE regimen was 18.7 months compared to single agent durvalumab, single agent tremelimumab, and a lower dose tremelimumab, that 75 mg dose with durvalumab combination. So the longest median OS was with T300, that is tremelimumab at 300 mg, a single dose, and durvalumab, and was also higher in this STRIDE regimen was median OS, more than 3.6 months longer. So it demonstrated an acceptable safety profile. So then we came to the Himalaya trial, which was a phase 3 randomized study in unresectable HCC patients, where they combined the STRIDE regimen. So here there were initially 4 arms, where the first arm A was durvalumab at 1500 mg, tremelimumab single dose at 300 mg, the STRIDE regimen. Arm B was single agent durvalumab 1500 mg. Arm C was sorafenib 400 mg twice a day. And arm D was the regimen that was again used in the phase 2 study, where they gave 75 mg of tremelimumab for 4 doses along with durvalumab. And after that, durvalumab maintenance. But this arm was later removed. The primary endpoint here was overall survival, and there was stratification on the basis of macrovascular invasion, the etiology of liver disease, whether it was HBV or HCV related or other non-viral etiologies, and the ECOG status. So the STRIDE regimen, a single priming dose of tremeli plus 1 dose of durvalumab, and this durvalumab is later in maintenance given 4 weekly, as compared to the other arms, as we can see here. So baseline characteristics were more or less equal in all the 3 arms. Here, if you see, if the viral etiology, HBV, HCV, and non-viral are well balanced among all 3 arms. If you see ECOG status, also well balanced between all 3 arms. Most of them were ECOG 0. BCLC status, BCLC-C were almost 80% in all the 3 arms. BCLC-B were around 20%. ALB status, ALB grade 1 and 2 were the majority. And if we see Child-Pugh status, Child-Pugh A was almost all of the patients were Child-Pugh A in all the 3 arms. PD-L1 positive status was also equal in all the 3 arms, around 37-38%. And if you see the AFP more than 400 nanogram, that was also almost equal in all 3 arms. So if we look at subsequent and second line anti-cancer therapies, targeted therapy was mostly used in the patients who received first line immunotherapy, that is either the STRIDE regimen or single agent durvalumab. And immunotherapy was used in the second line for patients receiving sorafenib. So there was a statistically significant improvement in median OS versus sorafenib, where if we look here, that median OS was 16.4 months versus 13.8 months in the sorafenib arm. So around a 3-month benefit seen here, with a hazard ratio of 0.78. If we look at the subgroups, The interesting thing here is that non-viral etiology also shows a benefit with the stride regimen. So if we are looking at patients with a non-viral histology, maybe this could be a better suited regimen than say the target therapy plus IO plus VEGF inhibitors. If we look at the other subgroups also here, the Durva Tremeli does quite well actually. Overall response rate and duration of response was also higher for stride compared to sorafenib. If we look at toxicities, any treatment related toxicity was lower with the stride regimen compared to sorafenib. Also, grade 3 and 4 toxicities were lower with stride regimen compared to sorafenib. Most common treatment related adverse events in the stride arm were rash, pruritus, and diarrhea. And as we can see, hypertension, hand foot syndrome was much lower in the stride regimen. So if you look at the treatment related hepatic and hemorrhagic events, hemorrhagic events were much lower in the stride regimen, but this hepatic toxicities were slightly higher in the tremelimumab durvalumab arm, and there were no esophageal variceal hemorrhage expected in the both the arms. If you look at the 5-year OS data, um, we see that the curves remain separated. Median OS 16.4 versus 13.7 months. If we look at the 5-year updated OS, again here we see non-viral histology, non-viral etiology shows a benefit with the stride regimen. And as we see, most of the other etiologies, there is a benefit, except I think HCV, for some reason, there is not a lot of benefit with the stride regimen, which I think we'll have to see why that is so. If we see etiology,
Sorry to interrupt. Just requesting you to conclude in next 2 minutes.
yeah. So as I just mentioned, HCV again not showing a lot of benefit. If we see the 5-year OS by baseline liver function, again there is a benefit with the stride regimen in ALB grade 1 and ALB grade 2 and 3, where the curves remain separated for both. So Durva and Tremeli has become category 1 first line therapy along with IO and VEGF inhibitors. And if we see, so I mean, concluding, there is a shift from viral to non-viral etiology in HCC in India, and the stride regimen has showed long-term benefits with 5-year OS rates of around 19.6 versus 9.4%. And this OS benefit has been seen across liver function groups, ALB grade 1 and ALB grade 2, 3, and there is a tolerable safety profile. And so it seems to benefit across all subgroups, including non-viral etiology population. So it continues to set a new benchmark in unresectable HCC, with 1 in 5 patients alive at 5 years. So this is a potential new preferred treatment option for patients with unresectable HCC. Thank you.
Wonderful presentation, Dr. Prabhat. Just want to know from you how at your center you are choosing between the two, atezolizumab and the stride regime. Is there any particular patient set based on etiology, based on clinical features, or whatever reasons where you are selecting the regime?
So I think it's even now it is very difficult to choose one regimen over the other. I think the point that we can start with is that those with CLD, portal hypertension, esophageal varices, where you should not use bevacizumab. I think in them, then the stride regimen automatically becomes the first line. Also, I think the non-viral etiology, there is data here as showed that those subgroups do better with the stride regimen. So I think that, and obviously I think liver function is a big factor. I mean, with stride, you know that there's a worse liver function, there is a chance of that becoming a problem later in the future. So I think that is the main factor how we should choose as of now.
Thank you, Dr. Prabhat. Thank you for the wonderful session.
Thank you.
So moving on to the next session, I invite Dr. Akanksha Chavda, Consultant Medical Oncology, Dayanand Medical College and AOI Ludhiana. She will be speaking on durvalumab plus gemcitabine cisplatin in the management of biliary tract cancers. Welcome, Dr. Akanksha. Over to you.
So thank you, Dr. Mukesh and organizers for giving me this opportunity. So I just want to share my slides. It's saying you can request the partner to send the request.
Dhruv, please share the slides.
No, I'll share. I just want the access to share.
Sorry,
Yeah,
sorry.
ma'am, you have access. You can share it from your side.
Are my slides visible?
Yeah, ma'am. Yeah, just make it full screen.
Yeah.
Yeah, now it's okay.
So a very good evening to all. Today I'll be discussing about the role of durvalumab plus gemcitabine cisplatin as new standard of care in first line biliary tract cancers, the real world experience. So according to the NCRP data, around 31,000 new BTC cancer cases they are diagnosed, and the highest rates are in India in the states of Assam and Delhi. Around 90% of the patients when they present to us, they are unresectable or advanced stage. And presently the standard of care, previously the standard of care was gemcitabine plus cisplatin. When we use this, the median overall survival was less than 1 year and 5-year OS was less than 10%. But recently, there is increase in the incidence of BTCs in both males and females, as you can see in this graph. So in the pre-IO era, we are talking about in 2022, the standard of care was gemcitabine plus cisplatin combination chemotherapy in the metastatic disease. This was established as a standard of care through this study, which is ABC-02, where gemcitabine cisplatin combination was compared with gemcitabine alone, and median overall survival was 11 months versus 8 months, favoring the gemcis arm. And the median PFS was 8 versus 5 months, again favoring the gemcis arm. So gemcis became the standard of care with no newer therapies improving the outcomes in advanced biliary tract cancers. Then what about adding maintenance therapy? Does adding maintenance therapy after GEMSIS has a beneficial role in some patients? So this was the study done for that, where after 6 cycles of GEMSIS, gemcitabine maintenance was given till disease progression, and it was compared with observation. And the results were that there was only PFS benefit and no statistically significant OS benefit. Again, another real world study studied it. It had the same after 6 cycles of GEMSIS chemotherapy. The maintenance gemcitabine was given versus observation. Now, if you look at this group, the second one, CC and CC1 group, these patients, they received the gemcitabine maintenance, and these patients, they were only put on observation. If you look at the median overall survival, the difference was 14 versus 11 months, favoring the CC1 arm, that is the patients who received gemcitabine maintenance. So it was concluded that there is a group of patients who were identified where survival could be prolonged by continuing the chemotherapy. But what extra can be done apart from adding gemcitabine as maintenance? So there comes the role of immunotherapy in first line advanced BTC cancers. This was the trial Topaz 1. We all know about this trial, which was a phase 3 randomized double-blind placebo-controlled study of Durva in combination with gemcitabine and cisplatin in patients with advanced BTC cancer. So the study design was very simple. They took patients of locally advanced or metastatic BTC, where they included both cholangiocarcinomas and gallbladder cancers. And if recurrent patients were taken, they were more than 6 months after the surgery or adjuvant therapy. Divided into 1:1 arm. One arm received Durva at the dose of 1500 milligram 3 weekly, along with Gemcis with up to 8 cycles. After that, only Durva was continued at the dose of 1500 milligram 4 weekly till disease progression. It was compared with placebo plus Gemcis. The primary objective was overall survival, and secondary objective were PFS and objective response rates. The baseline characteristics were well matched between the two groups. The median age was around 64 years, and all other criteria were well balanced, including mostly they were cholangiocarcinomas, which were metastatic, and female is to male ratio, they were also well balanced between these groups. Most patients, they were MSS, that is MSS stable, and PDL1 more than 1% and less than 1%, they were in 60s to 40 ratio. Now, these were the results. So the median overall survival in Durva plus Gemcis arm was 12.9 months as compared to only 11.3 months in the placebo plus Gemcis arm. But important point to note here is that if you look at the graphs, after 6 months, the graphs, they start separating and it remains separated even at 24 months. At 24 months, the overall survival was 11% versus 23%, almost doubling of the overall survival. So Imfinzi plus Gemcis is the first and only approved IO combination to show a 2-year sustained and durable overall survival benefit. Similar were the results with the PFS. If you look at this graph, again, this graphs, they start separating at before 6 months and they remain separated even after 1 year. So they give us the prolonged effect. The 12-month PFS was 6% in the placebo plus Gemcis as compared to 16% in the Durva plus Gemcis arm. The median PFS was 7.2 versus 5.7 months, again favoring the Durva plus Gemcis arm. So it also demonstrated a statistically significant and superior PFS against Gemcis alone. Now looking at the subgroup analysis, almost all the subgroups, they benefited with Imfinzi plus Gemcis combination, irrespective of the age, irrespective of the PDL1 status and the race, and irrespective of the ECOG performance status. They all favored Imfinzi plus Gemcis arm. Coming on to secondary objective, which was overall response rate, you can see very well in this graph that 24% overall response rate was provided with the Durva plus Gemcis as compared to only 18% with the Gemcis. Now, if you look at the patients who remained in response even after 12 months, it was 15% in the placebo plus Gemcis versus 26% in the Durva plus Gemcis. So it proved that 1 in 4 patients, they remained in response beyond 1 year with the use of combination Durva and Gemcis. Coming to the toxicity profile, all the new toxicity signals were, there were no new toxicity signals. The main toxicity were anemia, neutropenia, and decreased neutrophil count, but they all were due to the chemotherapy rather than the immunotherapy, and they both were same in both the arms. Looking at the toxicity or adverse events related to immunotherapy, they were usually low grade. Only 8 patients, they developed the immune related adverse events. Majority were dermatitis, which was well managed conservatively. Only less than 2% they experienced grade 3 or more toxicity. Coming on to 3-year overall survival analysis from Topaz 1. Again, if you look at the 3-year overall survival, the graphs, they remain separated. And the overall survival rate is 6% versus 14%, again favoring the Durva plus Gemcis arm. Now, this is interesting to note that at 1 year, if you compare Durva plus Gemcis with only Gemcis, 1.1 times more patients were alive in the Durva plus Gemcis arm. When it comes to 2 years, 1.7 times more patients were alive, and latest 3 years data says that 2.1 times patients, more patients were alive in the Durva plus chemo arm as compared to only chemo. Now, updated 3-year overall survivor data was presented in this conference, Cholangiocarcinoma Foundation 2024, which showed that overall survival at 3 months, it was doubled from 7% in the placebo arm to 15% in the Durva arm. So long-term survivors in BTCs, they are now becoming a reality. Coming on to effect of mutations on survival outcomes, post-hoc analysis of Topaz 1. The BTC cancers, they have mostly TP53, CDKN2A, KRAS, and other mutations. And if Durva plus Gemcis was given in these mutations, you can see this forest plot that in these mutations, Durva plus Gemcis, they were better tolerated in these participants, and with clinically actionable and genomic alterations, Durva plus Gemcis, it worked and worked better. Coming on to real world evidence. So we have 2 trials, one from Italy and one from India. Coming on to this Italian study, which was an early exploratory analysis of the real world data. So this was the results. When Durva plus Gemcis was given, the median overall survival was to the tune of 12.9 months and median PFS was 8.9 months. Adding Durva seems to improve the overall response rate, with more than 50% of the patients achieving the stable disease. And it had a very good objective response rate of more than 30%, that is almost to the tune of 35%, with 30% patients achieving the partial response. Coming on to the real world evidence from India. So this was the Indian study, GEMSIS and Durva Experience in Advanced BTCs, a real world multicentric data from India. This was published in 2024. And actually 14 centers, they participated from different states of India. And 148 patients, they were recruited with a median age of 57 years. These were the results. The median overall survival in patients with clinical benefit rate. So clinical benefit rate, it included the patients with the stable disease, with the partial response, and with the complete response. So median OS in those patients was to the tune of 23 months, almost 2 years. And this was achieved in patients of less than 60 years. More than 60 years, the survival was again dismal. Coming on to the PFS results, the median PFS was 8.2 months in these patients. Coming on to the safety and toxicity, no new safety signals were noted. The immune-related adverse events were seen in of grade 3 and 4 were seen in 11 patients. Majority of them had hypothyroidism, followed by skin reaction, which were well managed. So conclusions from the real world experiences. There are first two studies which reported the real world study of Durva and chemo. They are from India and Italy. So significant higher proportion of the GB malignancies they were seen in the Indian study, but PFS and OS and response rates, they were comparable to the original Topaz 1 trial. The overall survival was also equivalent as to the Topaz trial in the Indian study as well as the Italian study, with no new safety signals, and toxicity was acceptable. So the combination of Durva and chemotherapy appears to be safe and efficacious regimen in BTCs. If you look at the latest guidelines, that is the NCCN guidelines in 24 and 25, now Durva plus GEMSIS has become the preferred modality and the standard of care in patients with the metastatic gallbladder cancers. So this is the category 1 recommendation now. So to conclude, Durva plus GEMSIS demonstrated statistically significant and clinically meaningful prolonged OS as compared to placebo plus GEMSIS in the phase 3 real world studies as well as the Topaz 1 trial. The 3 years OS data rate in Durva plus GEMSIS arm was more than double as compared to the comparator arm. It was 6% versus 14% favoring the Durva plus GEMSIS. It did not add into additional toxicity. It means that there were no new safety signals, and Durva plus GEMSIS appear to be effective across the molecular landscape of BTC, and patients with targetable genomic alterations, they also benefited from this combination. Imfinzi at the dose of 1500 milligram in combination with chemotherapy is now approved as category 1 indication, also approved by DCGI in patients with locally advanced and metastatic BTCs. So Topaz 1 is the first global phase 3 trial to report the positive results with IO, that is Durva, and chemotherapy, that is GEMSIS, with similar results from two real world experiences, which is now the new standard of care in the first line treatment of advanced biliary tract cancers. So that's all from my side. Thank you for the patient listening, and thank you organizers and Dr. Mukesh again for giving me this opportunity.
Thank you, Dr. Akanksha. It was a nice and engaging presentation. Just one question for you. How confident you are after this data for using durvalumab in biliary tract cancer? Is there any difference if the patient is of gallbladder or cholangiocarcinoma for you?
So if you look at the trial, majority patients, they were cholangiocarcinoma, but now cholangiocarcinoma plus gallbladder as metastatic, we treat as one entity only, whether they are from cholangio or they are from gallbladder. So I prefer Durva plus GEMSIS as my category 1 recommendation, and I counsel all the patients to take the same.
Thank you. Thank you, Dr. Akanksha. So moving on to the next session, we will be having a very nice discussion on clinical insights and ESCO updates in GI cancers. So I invite Dr. Navdeep Singh, who is consultant medical oncology at AOI Hospital, Jalandhar. Dr. Navdeep, yeah.
Yeah, am I audible?
Yes, you are audible, Dr. Navdeep.
Okay. Can I share my slides?
Yeah, sir, I'm sharing.
Thank you, Dr. Navdeep, for accepting the role at such a late hour. You really
Uh,
saved the day.
I'll try my best to discuss all
Yes,
these
yes,
four
yes.
abstracts. Okay. So first abstract is we are using adjuvant nivolumab in secondary esophageal G-junction cancer. Final analysis of overall survival from checkmate 577. Next slide, please. Next slide, please. So as we know, in this checkmate 577, adjuvant nivolumab demonstrated statistically significant and clinical DFS benefit versus placebo. Almost doubling of the DFS was there. We know this is now the only approved immunotherapy in this setting, but yes, OS data are lacking in this setting. So we'll discuss the final analysis of this trial. Next slide, please. So in this trial, we know in the trial design, the patient of stage 2-3 esophageal carcinoma or G-junction carcinoma, whether adeno or squamous, they were randomized, well screened and randomized the patient having residual pathological disease, any T1 positivity or pathological node positivity to adjuvant nivolumab versus placebo. And the treatment duration was up to 1 year, and the primary endpoint was the DFS, and the secondary endpoint of the overall survival. Next slide, please. So baseline characteristics were well matched in the both the groups. The common histology being adeno-CA. Next slide, please. And again, the patient or almost 1532 patients were there, and then they were randomized. Next slide, please. Coming on the disease-free survival, as we already know, the disease-free survival was doubled in the nivolumab group. It was 21.8 months versus 10.8 with a hazard ratio of 0.76. Next. And if you see the distant, even the distant metastatic free survival, again, it was more with the nivolumab 27.3 versus 14.6 with a hazard ratio of 0.75. Next. And coming on to the overall survival, yeah, we are see the overall survival, although numerically it is 51.7 months compared to 35.3 months, but the hazard ratio was only 0.5. It was not a statistically significant. But this is a clinical meaningful improvement in the OS. Next slide, please. So again, if you see, these are the all the subgroups. And if you see the overall survival, they favored the patient which are having PDL CPS more than 1 as compared to those less than 1. Next, please. And as if we see the overall survival, both the PDL with the CPS, in the CPS more than 1, it was 45.5 versus 33.1 with a hazard ratio of 0.79. Compared, if you see in the less than CPS 1, it favored the placebo group. Next slide, please. So again, if you see the overall survival adjusted for the subsequent therapy, see how many patients they received subsequent therapy. The subsequent therapy was received more in the placebo group compared to the nivolumab group. Next. Yeah, safety summary, not the major side effects were there. Next slide, please. So after 5 years of median follow-up, we know that DFS improvement was there. It was almost doubled. But yes, there was 16.4 months of a numerical OS benefit, although it was not as statistically significant with a hazard ratio of 0.85. But I think it's a clinical meaningful benefit as nivolumab is a well-tolerated drug, and there were no new safety signals were reported with longer follow-up. Next, please. Next, please. Next, please. Next, please. Next. So next abstract I'm discussing is the breakwater, in which we are discussing the BRAF and corafenib, in which it was added to cetuximab plus chemotherapy in a BRAF mutant metastatic colorectal cancer in the first line setting. Next slide. Next, please. Next, please. So we know from background these mutations occur in 8 to 10%, 12% of patients of metastatic CRC. So this encorafenib is a highly sensitive ATPA competitive small molecule BRAF inhibitor. So preclinical data have demonstrated the combinational benefit with the drugs like cetuximab and cytotoxic therapy. And we know we have a data with the in second and later line setting. So this was the first study in which the combination with the cetuximab was seen in was studied in first line setting, metastatic setting. Next, please. So coming on to the design, all the patients which were having no prior systemic treatment for metastatic, and they are having BRAF V60 mutant metastatic CRC, and the patient should be having adequate good performance status with the adequate organ function. So patients were randomized to the three group. One group was the combination of this BRAF inhibitor with the cetuximab, and the second was the combination with the chemotherapy arm, and the primary endpoint was the PFS, and the secondary endpoint was the overall survivor. Next, please. Next, please. So if you see the again the most of the time the duration of treatment in both the subgroup was around 28.1 versus 24 months, and the median who follow up for median overall survival was 10.3 versus 9.8 months. And in the even in the combination arm, most of the patient, like around 58% patient, were undergoing treatment. Next, please. And the baseline characters were suitably matched in the both the groups. Next, please. So see if the see the confirmed overall response rate. So if you see the overall response rate in this combination of the Folfox versus BRAF inhibitor plus cetuximab was 60.9 versus 40% in the other arm in the the overall patient had the 2.7% has complete response with the partial response in 64% of patients, and the duration of response, which are more than 6 months, was seen in more in the combination arm than in the control arm. Next slide, please. So even if you see with the in the subgroup analysis, all the factors favored, whether it's the performance status, the site of tumor, and baseline or number of organ involved, or even the liver mets, most of them favored the combination arm. Next, please. And if see the overall survivor, if you see the over the curve started to separate early at 6 months, it was 90.3 versus 87.1, and the 12 months, it was 79.5% and 66 in the other control arm, and with the hazard ratio of 0.47. Next, please. And yeah, we are all concerned about the safety summary because with chemo plus cetuximab and BRAF inhibitor, I think it's a quite a toxic regime. Yes, definitely. Compared to the control arm, there are a lot of common side effects with the this combination. Next, please. And these were the most frequent all type of side effects which were seen more commonly in the combination. Next, please. And there were patients like around 27% patients had a discontinuation in corafenib arm, and there were also dose reductions and dose interruption in the combination arm, which were definitely more than the control arm. Next, please. So coming to the conclusion, again, this study demonstrated a clinically meaningful benefit over a response rate, uh, and the it's I think it's a quite a toxic regime, but according to trial, this is a combination were is generally well tolerable. Yeah, but in the BRAF mutant, we know these patients are these type of patients they behave very aggressively. So possibly we can use this combination in such type of patient. Next, please. Next, please. So next abstract I'm talking is about the Matterhorn. It's a study in which Durva is combined with the plot, which is now a standard of care in the perioperative setting in GE junction and specifically the adeno-CA. Next, please. Next, please. Coming into the background, again, we know plot is now a standard of care for the perioperative setting in GE junction and G junction adeno-CA. So again, we know the whenever we add anti-PD-1 therapy, there is a definite improvement in survival. So adding Durva in this perioperative setting to plot was studied in this studied in this trial. Next slide, please. So the primary endpoint was event-free survival, and the secondary again being overall survival and also the pathological complete response. Next, please. So see the patients and the combination of Durva plus around both the patients were around 474 patients, and most of the patient they completed the treatment, and R0 section patient rates in which who completed surgery was around 92%. Next, please. Baseline characteristics were well matched in the both the subgroups. Next, please. So coming out to the secondary endpoint overall survival, see the median overall survival is still not reached in the combination of Durva plus plot arm. And you see, can see the difference of curves at 18 months and 24 months. So in the placebo plus float arm, it's 47.2 months, and the hazard ratio are favoring the combination of Durva plus plot with a statistically significant p-value. Next, please. So again, we know the PCR is a definitely predictive marker of survival. So in combination arm, the Durva plus plot, it was 19% versus 7%. Then the only plot arm. Next, please. So if you see again the secondary endpoint like disease-free survival still not reaching the Durva plus plot arm, a difference is still present at 18 months versus 24 months also, and with a hazard ratio of 0.7. Next, please. Next, please. So I think most of the time there were not a big difference in this combi. We know plot is a toxic regime, but with the addition of plot, I think there were not much safety signal. Yes, a few patients had some grade 3s or immune related adverse effect. Next, please.
Hello, good evening, sir.
Next,
Hello.
please.
Hello.
So coming to conclusion, so Durva plus plot, it significantly improved event-free survival versus plot alone, and EFS benefit was consistent in all the subgroups, and there were no new safety signals were identified. Next, please. Next, please. Next, please. Next. So coming to the last abstract, in the we know in the resectable colon cancer stage 3, we only give adjuvant chemotherapy 5-FU base. So in this study, LBA1, in the patient who were having the DNA mismatch repair deficiency, the atezolizumab was combined with the adjuvant chemotherapy. Next, please. So next, please. So again, we know standard adjuvant therapy we use, and 15% of patients have a deficient MMR. So again, to 30% patient in stage 3 may experience recurrence. So to add on the benefit of in this subgroup, this drug immunotherapy was added. Next, please. So study again the patient after these patients who are having underlying confirmed stage 3 disease with having deficient MMR, they were combined, they were randomized to chemo plus atezolizumab, which was further followed by atezolizumab maintenance versus the standard chemotherapy. Primary endpoint were DFS versus Candiva overall survival, any adverse events. Next, please. Next, please. Next, please. So again, these are the two arms which were in which it were randomized. Next, please. Baseline characteristics were well matched, and there were both low risk stage 3 and high risk stage 3 patients. Next slide, please. Next slide, please. So coming out the primary endpoint, DFS at 36 months, it was 86.4% versus 76.6% in the only chemotherapy arm with a p-value, a significant p-value in the hazard ratio of 0.50. Next, please. And if you see, even in the patient having underlying, which are having deficient MMR, the benefit was DFS benefit was more in the combination arm within compared to the standard chemotherapy arm. Next, please. And a DFS, it all favored most, it favored the combination of FOLFOX plus atezo arm. Next, please. OS data is still not mature. Next, please. So safety summary, I think there were most of the side effects were well managed in all the subgroups. Next, please. Next, please. Next slide, please. So coming on to the conclusion, AT plus FOLFOX, it demonstrated a statistically significant clinical meaningful 50% reduction in recurrence or death over only chemotherapy. It's the safety is in line with the known safety profiles of each drug. And yeah, it's definitely, we know there is always a gap in such patient where we can add some additional therapy or give the maximum benefit. Atezolizumab is, I think, a good drug to give in this adjuvant setting. Thank you.
Excellent presentation, Dr. Navdeep. You have done a great job. I think to the conclusion is immunotherapies, like all cancers, have come a big way in the entire GI tract, be it in the adjuvant setting, in the metastatic setting, now in the neoadjuvant setting.
Yeah.
We have seen the data, we have seeing the practical results of nivolumab in adjuvant upper GI cancers. Now it looks a very exciting trial, which you have mentioned, atezo plus FOLFOX, especially in MMR deficient, because here we know the tumor is chemo resistant. So it looks exciting. Thank you for the presentation.
Thank you, Dr.
So moving to the next session, I invite Dr. Syed Nisar sir. Is Associate Professor, Department of Medical Oncology at SKIMS Srinagar. Welcome, Dr. Syed Nisar. Over to you.
Good evening, sir. So at the outset, I thank you, the organizers, for this opportunity. So I will be discussing HCC. Yeah, can we have my slides? Yeah. So I will be discussing atezolizumab in unresectable HCC from clinical trials to the real-world experience in Indian patients. Next. Next slide. Yeah. So this is a Roche presentation, and the slides are from the Roche only. Next. So we know after sorafenib, there was a gap of a decade when we had this breakthrough trial in 2019 by Dr. Richard Finn. So this IMBRAVE 150 was a phase 3 data of 80 plus BEV in patients with unresectable HCC. The patient characteristics were locally advanced or metastatic or unresectable HCC with no prior systemic therapy. And they were stratified depending on region, ECOG, PS, macrovascular invasion, extrahepatic spread, and baseline AFE less than or more than 400. And the co-primary endpoints were OS and PFS with independent review facility as with the RESIS 1.1, and the key secondary were response rate. So ATBEV was the arms, and the comparator was the standard of care at that time, sorafenib, and the treatment was continued until loss of benefit or unacceptable toxicity, and they were watched for several follow-up. And here to note that is this trial included high-risk patients, and 20% were having like macrovascular extrahepatic, and also there was invasion of main portal vein bile duct in more than 50% had liver occupying tumors. Next. So this were the baseline characteristics. They were matched, and most of were in 7th decade of life, majority men, and they were both Asian and rest of world. And again to note was they had a PS of 0 and 1. An important thing to note is that this trial took patients with child poor A5 and 6. So majority two-third were with A5, and A6 was around 28 or 27% of patients. So which is basically not seen most of times in the real world practice. And also they had included patients with both viral and non-viral etiology, although majority were from hepatitis B related ICC, and around 1/5 of patient had ICV related, but 1/3, 30% had non-viral etiology as well. So then a good number of patients had extrahepatic involvement, macrovascular involvement. Next. So you can very well see these Kaplan-Meier survival curves. So if we see PFS, which was a co-primary endpoint, the median PFS was 6.8 versus 4.3 with the sorafenib. So with a hazard ratio of 0.59, so you can see that it's a good hazard ratio, and the curves are well apart. So this became a new standard. Next. So the updated OS data also showed the significant survival benefit. So it was median OS was 19.2 versus 13.4. So again, if we see at 6 months and 12 months and 18 months, so the benefit continues, and they continue to be well apart. So this became the standard of care ATBEV in advanced ICC. Next. But the question remains, do we find the same benefit in real world where we have much advanced disease and we have the child who may be B or even C? So what is the data for real world evidence for ATBEV in ICC? Next. So these are the sources other than traditional clinical trials. So they ideally mirror the reference clinical cohort, and this checks the clinical benefit outside the clinical trials. Next. So this was the APA real trial. So this the study basically it was the largest real world clinical data. So this basically was a retrospective data, prospectively maintained data of these patients, and the huge number of population 433, and they include patients from US, Europe, and Asia. So in addition, they included some patients with childhood B and C, and so they exclude actually, and again the PS2 and 3 were excluded. So the characteristics were almost same as was the trial. So majority, the median age 66, male majority 80% of the patients, and 0 and 1 was the PS. So other characters like was seen in the IM-Brave trial, like extrahepatic AFP more than 400. So they were almost matching. So in addition, they checked LB1 and 2. So LB1 score, which is a prognostic in ICC, it was seen around roughly half 1 and half in 2. And the cirrhotic were majority. And again, the viral etiology was the commonest which had led to HCC. Next. So if you see this real world observation data, AB real OS as well as PFS, and if you compare with the IMBRAVE trial, so you see these curves almost are similar, they match. So in both PFS as well as OS. Next. The highlights of AB real was that objectives of baseline characteristics as prognostic factors, association of prognostic factors with outcome, and the prognostic role of baseline characteristics like AFB less than or more than 400, child 6 versus 5, portal and thrombosis, LB 1 versus 2, radiological response, and extrahepatic. So they were related to outcome. Next. So, but of course, we know this was a prospectively maintained retrospective data. There could have been some missing information, especially comorbidity and endoscopic catches. So quality of radiological assessment and response. But with this caveat, also the AB real global observation study confirms reproducible safety, tolerability, and efficacy of etibev in routine clinical practice. In other analysis, etibev has been explored as an option outside of IMBRAVE 150 setting. The combination appeared safe and effective in an older cohort of patients. ICC and preliminary evidence of the combination's efficacy and tolerability in child B have been reported. Next. So what is the Indian real-world evidence for etibev in unresectable advanced HCC? Next. So this study from this was basically data from Asian Institute of Gastroenterology, Hyderabad, and Jaipur. So this was the two institutional combination published data. So the child pool class determined the outcome of patient advanced HCC. So treated with etibev. So this was a real world experience. They included 67 patients treated with etibev and to assess OSPFS adverse events among the different child. So that was the main aim. Next. So 67 patients, the age slightly lower than what was in the trial, 61 median age, and around 60% constituted by male. So here in some characters like varicose bleed in around 1.5%, high risk 9% of patients, and these were the like ligation number of treatments. So here in around half of the patients were NASH-related HCC, and viral etiology constituted 19 and 16% respectively, and there were patients with alcohol and cryptogenic etiology as well. So around half had baseline AFP of more than 400, and ECOG PS0 and 1 was seen in around 60%. So the important to note is that we had patients with child A 35%, child B 53%, and 10% were from child C class. So it was not actually seen in real in actual clinical trials. So they have only taken child A. So again, there were patients who had extra hepatic spread, microvascular, and both, and prior treatments were like TR, TACE, microbial embolization. There was a patient which was actually post-transplant. Next. So here in what the important thing we see the survival outcomes with vis-a-vis child score. So this is, you can see the with A, what is the outcome, 21 months OS, and once it drops child to B, it is 9 months only, and in child to C, it is only 2 months. So it is 4 months only. So again, this is basically again reproduced in PFS. So with child A 18 months, B 8 months, and with C 2 months only. Next. So this is the toxicity total 64, and majority had low grade only toxicity, and this is already shown in the table. Next. So important again is that the toxicity increased with the child poo score. So you can see the cumulative toxicity overall 12% in child poo A, which went up to 14%, slightly different from child poo A in child poo B. But in patients who had child poo C score underlying, the toxicity was 85%. Seen in 85% of the patients. So they had a high toxicity and low benefit. Next. So the summary of the study was selecting the right patient is the key to success. Child C should not be given this treatment. Variceal bleeding is less than feared. So patient with a history of variceal bleeding and portal vein thrombus, of course, should be monitored cautiously, and upper GI endoscopy all yes, but prophylactic bandy is not needed in all patients. Next. So what is the other important real-world evidence? Next. So these are other evidences which again depicts that as the liver function, so there's deterioration. So from A to C in child poo, the outcome is worse. So in different studies, it depicts so it is correlated with the child poo class. Next. So meta-analysis of systemic therapy. So next. So basically, this is to compare this is a cross comparison with different drugs in different populations. So actually 23 studies and 3,000 patients, and so outcome include pooled response in the form of OR, CR, PR, median OS, PFS, adverse events. The pooled median OS and PFS were 14.7 months and 6.66 months respectively, and during the treatment, 30% of patients had grade 3 and more adverse events. So again, the etibev showed good efficacy and tolerability in the treatment of advanced SCC. Compared with short-term, non-first-line low-dose etibev showed better response in long-term first-line standard dose treatment for advanced SCC. Next. So again, the meta-analysis too, the CINS studies show variable efficacy across lines. A meta-analysis, network meta-analysis NMA helps in comparing different agents across randomized clinical trials. So the current systemic treatment options for are like we have VEGF plus checkpoint inhibitors or the combination of checkpoint inhibitors, but there's lack of clarity from current guidelines, which is better. So lack of clarity regarding benefit of one drug over the other in real world setting, and because of lack of comparative data. So head-to-head comparison between most of the agents, available agents has not been perfect and less likely in the trial. So next, sorry, next. So these are the studies identified, and ultimately 14 studies included in the quantitative synthesis meta-analysis they were studied. Next. So if we compare first-line agents, the etibev had shown the benefit in comparison to all the drugs. So you can see the hazard nivolumab, lanvatinib, sorafenib, and others. And overall, all drugs except sunitinib showed OS advantage vis-a-vis placebo. Next. So the OS benefit, the combination of etibev showed OS compared to all treatments we discussed, and etibev and lanvatinib showed PFS benefit over sorafenib. And etibev ranked highest in terms of the PFS and OS. So with a score of 94.16 and 99.65% respectively. Next.
Sir, sorry to interrupt. Just want to request you to conclude in next 2 minutes.
Yeah, just concluding within 30 seconds. So this is the suggested treatment algorithm for patients with advanced SC. The first line advanced, so if immuno is contraindicated, then we can of course choose say like sorafenib, lanvatinib, so lanvatinib most of times. Otherwise, so etibev, or if we have option of immuno. Next. So if you see the ranking, so Etibev standard is first compared to others. Next. Again in PFS, same. Next. So this is with already discussed ranking in OSPS and PFS. So again, Etibev scores vis-a-vis others. Next. So to summarize, Etibev combination shows superior OS and PFS benefit compared with placebo, sorafenib, lenvatinib, and nivolumab in first-line setting for advanced HCC. Atezolizumab and bevacizumab combination is a standard of care in the first-line setting in patient with advanced HCC. Next. One more slide and thank you. So the absence of evidence is not like is not the evidence of absence. So thank you for your patience here.
Excellent presentation, sir. So just want to learn from you, as many of our patients are child pug B in the real world scenario, and the trials restrict the use to child pug A. What is your practical experience? How you decide of using the drug? Do you limit it to B7, B8? Or what is the criteria you use?
So yes, of course, but now we have evidence from real world practice that we can use in child pug B. So child pug B, we do use because our patient profile is different from the Western. We get most of patients with child pug B. But of course, there's no suggestion that we should use a child pug C because of lack of benefit as well as toxicity. But with caution, but we do use in child pug B.
And sir, any word on, like, we now have stridazine also, we have pembrolizumab coming up also. Do you decide choose your drug based on the etiology or any specific?
So of course there were concern like viral versus non-viral, but overall the consensus is it works in both. And say we have Himalayan, it has also showed. But of course, if there is a contraindication for like bevacizumab, then we have constraint in using this, and then we can use like immune with other combinations. So that is the major, that is one of the concerns, especially say like we have high-grade viruses, uncontrolled proteinuria, hypertension. So those situations where there's a contraindication. Otherwise, we have a good experience and long experience with Etibev.
Thank you, sir. Thank you for the
Thank
presentation.
you very much. Thank you.
So now moving on to the next presentation. Now we are moving to hematology section. So I invite Dr. Burhan Wani, consultant medical oncology, AOI Jalandhar. He will be moderating the session on platuzumab vedotin in first line DLBCL. I think Roche wants us to learn it again and again because maybe DLBCL is an aggressive and heterogeneous disease. So they remind us again and again to hit hard in the first line also, because the relapsed DLBCL, as all of us agree, has a very poor prognosis. So so you invite your panelists, Dr. Burhan sir.
Yeah, thank you, Mukesh, for the kind introduction and for setting the context. I think as you have pointed out, so our topic will be it will be a panel discussion, and my panel discussion will be focused on the first line management as far as the DLBCL is concerned, with a focus on the polatuzumab. Along with that, we have the recent data, 5-year data from the polatuzumab POLARIX trial. So that we'll be discussing, keeping that also into consideration. So to begin my panel discussion, I would like to call on my panelists. I think I have my panelists, Dr. Deepak.
Here.
Dr.
Yes.
Deepak is here.
Yes, yes, I'm here.
Good evening.
Good evening.
Yeah, good evening, Dr. Deepak. Dr. Arun Raja.
Yes, sir. Good evening, sir. I'm
I
here.
have seen him now. Yeah, good evening. Dr. Mir Hussain.
Yes.
Dr. Hussain.
Yes, yes.
Yeah, good evening. Good evening. And Dr. Aditya.
Good evening, everyone.
Dr. Aditya.
Hi, Dr. Burhan. Hi.
Yeah. Yeah. And Dr. Nitish, again, and dear friend.
Hello.
Dr.
Yes, sir.
Nitish.
Hello. How are you? Hello, everyone.
Yeah. Good. Great. So I think we have all the panelists, so we'll be starting. Yes. So as has been pointed out, this is the disclaimer is that this is a Roche sponsored session, and all the slides and the study material has been provided by the Roche. So coming to I will be straightway going with the cases, and I think that will give us a discussion point as well. So this is the case one. We'll be discussing various case scenarios. So this is the first case where we had a young patient who was a 48-year-old male who presented with abdominal pain, lower back pain associated with a weight loss for 3 months. The physical examination revealed there was a palpable abdominal mass with flank tenderness, with a lab investigation showing elevated LDH. CT abdomen was done, which showed there was a thickening of stomach wall and multiple enlarged lymph nodes and a mass in the right kidney. Upper GI endoscopy was done, which showed a large gastric mass with a biopsy showing features of DLBCL. IHC showed non-GCB type with a CMYC positive and BCL2 positive. FISH for CMYC was negative. ECOG performance was 1. The final diagnosis was having a stage 4 disease with an IP of 3. So overall, we do see come across this site of this sort of a presentation in our clinic practice. And what the important clinical challenges are that we have to predict the patients at the high risk of progression on the first line of therapy, and the treatment outcome as far as the high IPI is concerned, non-GCP, and the double expressor lymphoma is concerned. So I would like to know from my panelists that to start with Dr. Deepak, how will you treat this patient in the current era? So
yes, yes. First of all, I would like to do one PET scan as well. I think PET scan was not done. If possible, we should do the PET scan. And it seems to be a double expressor lymphoma, as it is CMYC and BCL positive. But the only thing, definitely, I would like to give the best therapy, like. Uh, but we can go ahead with the this antibody conjugate this polatuzumab plus rituximab and remaining our cyclophosphamide.
So you will be choosing a polar R-chip based therapy in this patient.
Polar R-chip, but the only my concern is that in that trial, whereas I think the age group is, everything is fine, but high IPI score is there. The only thing is which is bothering is the only age group. My only concern is that.
You feel that the younger age group population might not be the candidate, or will be less benefited? Is it like that?
No, but as per the trial, the median age was approximately in the both the arms was in RTOP and RCP arm. It was 60 plus. It was arm was there. So if that is not contraindicated, I would like to give him the best therapy. Including the antibody.
I think DLBCL, we know majority of these patients, they tend to be elderly, these of most of the time, but we come across patients at a younger age as well. So Dr. Hussain, your take on how to see these patients in the current area, current era, how we are treating these patients. Do you treat with the same treatment, or you see them differently with the choice based on IP and cell of origin and the age, as was pointed out by Dr. Deepak?
Yes, yeah. So this is a very heterogeneous disease, what we know, but what types we know is commonly we divide in between GCB and non-GCB, what we usually call as an ABC type. So this patient is an ABC type. There is no defined regime, but if we look at the results of this OLA RCHP trial, Polar X, that has definitely shown that this group of patients is going to have a huge benefit by exposing them to the polatuzumab or CHP based regimen. So if he has finances, I will definitely prefer to give him Pola or CHP based regimen.
Okay. Dr. Aditya, your take on this patient?
Good evening, everyone. Yeah. Am I audible?
Go ahead.
Yeah. So I agree that this patient has like gastric involvement, renal involvement because of DLBCL, and I feel that because there are more than one extranodal site, so we should do a PET scan at baseline. The second thing is like as far as the treatment is concerned, and another thing from the evaluation point of view, I would like to get an upper GI endoscopy as well. In this case,
upper GI has been done already, so we have upper GI based on that was diagnosed biopsy.
Okay, so that's great. From the treatment standpoint, I agree that if finances allow, I would include polatuzumab to RCHP in the frontline treatment. Having said that, in the ABC subtype, we have clear benefit with the polatuzumab based regimens. However, if the finances do not allow, this patient has double expressor lymphoma, FISH is negative, and age is 43 years old. If I cannot add polatuzumab, then I would strongly consider possibility of DA-PACOR in this case. Yeah, and in addition to that, because of kidney involvement, intrathecal methotrexate with each cycle, and maybe 2 cycles of high-dose methotrexate at the end of 6 cycles.
Yes.
Thank you. Dr. Nitish, your take?
I think definitely this patient needs a PET scan. And adding on to Dr. Aditya's point, upfront CSF also would be of help. A young patient with a renal involvement, let's not miss out on CNS involvement in this case because there is a gastric involvement, there is a renal involvement. So a CNS evaluation, I mean CSF evaluation for a upfront evaluation, definitely. And I would definitely add a polatuzumab in this patient.
Dr. Arun, do you like to add anything what the panelists have pointed out, or you have any other observation?
Yeah, I have one thing to add upon. So we have a trial called Remodel B from UK trial. So it shows that ABC variants adding R-CHOP with bortezomib, there is a survival benefit. So that's a missing thing, I guess, from the panel discussion. Otherwise, I do agree with all the inputs.
Okay, great. So if we see because our focus will be mainly on the POLARIX trial. So if we see this study, the initial PFS benefit that was seen, followed by now the 5-year data is available, that it has shown that this PFS benefit, it continued beyond as well. And there was a separation there was sustained a significant PFS benefit, and which confirmed the results from the primary analysis at the 2 years. And same was treated as far as the disease-free survival was concerned. The complete remissions were durable and sustained with longer follow-up. And although OS is still, we are not finding trial, but that was statistically significant, but there was some numerical benefit as far as the OS again in this POLARIX was concerned. So as has been pointed out by all the panelists, that definitely as far as the choice of therapy is concerned, it will be determined by the high versus the low IPI. And if we see the previous studies where we had the R-CHOP based therapy, the IPI played a significant prognostic role. Patients having the high IPI, they tend to behave they had the worse survival than patients who have the low IPI. So that we know. And if we see the POLARIX trial, as we pointed out by Dr. Deepak as well, that IPI high was the subset of patients where the Pola R-CHP, it showed the benefit as compared to the R-CHOP based therapy. So again, as has been pointed out by Dr. Hussain, that about the cell of origin, we know that the DLBCL is sort of heterogeneous disease. And we have the GCB and the non-GCB type. Based on the molecular profiling, we have various subsets of the DLBCL as well. And if we see the POLARIX trial, again, variant was concerned, and than the GCB. So these are some of the points that we will consider once we are seeing a patient of DLBCL, especially the high IPI type. Now, the other thing, I think double expressors has been pointed out. I would like to, because we have now another sort of case. So it was a 60-year-old patient who presented with a bilateral clinical neck swellings with fever, with a weight loss, ECOG performance of 2, with a hypertension and diabetes as comorbidities that were controlled on medication, with a PET-CT showing a hypermetabolic diffuse lymphadenopathy on both sides of diaphragm, with bone marrow involvement. LDH was elevated, IPA was 5, and CNS IPA of 5. The biopsy confirmed there was aggressive CD20 positive B-cell lymphoma with immunophenotyping confirming BCL2 positive, CD10 positive with CMYC positivity, and Ki67 of more than 90%. And the final impression was a double hit lymphoma, which was MYC and BCL2 positive. So as far as, again, there are clinical challenges as far as management of these patients, the tolerance of intensive therapy in the older patients with a high CNS risk of relapse. So again, I would like to know from my panelists, so how they are treating these patients in the current era. What are the various unmet needs that they face as far as the management of this patient is concerned? So I will start with Dr. Arun. So how you see these patients and how you treat these patients in current era?
My practice, I just so for example, for this patient, it's a high grade lymphoma with CNS involvement, high CNS IPS score. So I just go with the R-CHOP with the day 15 of high dose methotrexate as my consolidation. So that is how I treat. Sometimes if I don't feel like what to say, I can use the if he is not in good performance status, dose adjusted epoch can be considered. But in my routine practice, I use R-CHOP with high dose methotrexate, day 15 consolidation. So,
okay. Dr. Aditya, your point on the double hit lymphomas, do you treat them differently or currently you are treating the same regimen?
So I think wherever possible, we do consider addition. We do consider DA-POCAR in such patients. Although we have now some of the studies have shown that there is no difference in terms of no major difference in terms of outcomes. We know that these patients are not going to do as well as a common garden variety of DLBCL. But I think DA-POCAR, wherever the patient can arrange, socio-economic support for regular follow-up. If that's possible, we go ahead with DA-POCAR. Otherwise, as mentioned by Dr. Arun, we go ahead with R-CHOP. And we give high dose methotrexate at the end of 6 cycles, not in between. IT methotrexates definitely with each cycle.
Okay. And what about Polar-CHP in double hit? Any experience or?
No personal experience as such, sir. I have used it in some of my patients who are ABC subtype and high IPI, and they have done well so far. So not particularly in double hit.
Dr. Nitish, your take and how you see these patients double hit versus the conventional lymphoma, the DLBCLs.
Right. So, this patient, basically, I would like to know what was the MYC fusion or translocation. Are we going to treat it as a Burkitt? Is it a Burkitt's, and are we going to treat it like a Burkitt's or not? Because we have mentioned in the diagnosis that it is a double expressor, but we have no.
So it was actually it was fish. Yeah, it was fish positive. So
then
it
what was the translocation for MYC?
So I don't know for that, but definitely fish
Okay, so
was
so
positive, and based
we
on
assume,
that,
correct, sir. We assume that it is not a Burkitt's. So if not
yeah.
Burkitt's, elder if the patient is elderly, has a poor performance status with the bone marrow involvement, assuming that there will be some effect on the TLC and also the DLC with the platelets, I might be considering a POLA-based regimen. If the patient is very fit, there is no effect on the hemogram with TLC and platelets are normal, I might be considering R-diapoc, though it has shown that it is not giving a greater benefit compared to R-CHOP. But yes, these young patients need a better drug because we know this is going to be an aggressive disease.
Dr. Hussain, how you are treating your patients of double hit, and what has been your experience? Any experience of polatuzumab in these patients?
See what Dr. Aditya said, they are very high risk group of patients, these double hit. If we have proven that he is a double hit with MYC and BCL2 positive, so he is 61 years old, I think I will prefer in such set of patients DAR epoch. R-CHOP is inferior. So whatever literature we have that always prefers a regime which is not R-CHOP based. So they may be non-R-CHOP, like DA epoch will be the first line consideration in such cases in our scenario. So we treat them with DA epoch. But if he is a young, fit patient who is PS is very good, so we will usually consider giving some induction with which has a CNS penetrating drugs. We have few patients we have treated them with or Codox MRIVAC upfront, and we have a patient who is on our follow for last 3 years. She has done very well once we treated her with R Codox and RIVAC, and in one or two cases we have used it upfront hypercvad RMA. So, but my point is that R-CHOP is very inferior. In if you have proven it is double hit, double expressor we can give, but in double hit we have to see some non-R-CHOP based regimen. What other panelists say that DAPOC and then other these regimes. We have used one or two patients we have treated with hypercvad, MA and R-Codox and RIVAC. But this case I will treat with DAR epoch with CNS therapy as an
younger
intrathecal.
patient, if we have a younger patient with a good comorbidity profile, so what about using our CHOP based therapy?
That is that is
there
another
any how you
regimen.
see?
Yes, where there is some benefit of adding etoposide, because etoposide is again a good CNS penetration. So that regime is there that can also be used. But if you have a young fit patient, where I think I will prefer to give R Codoxam, R IVAC, or R hypercvad MA, or otherwise DAR epoch. But I will not use R CHOP.
Yeah.
May I add something, Dr. Burhan?
Yeah. Yes.
The although we have like evidence that Pola RCHP was beneficial across the subgroups when the investigators looked at the subgroup analysis. Although we always look at subgroup analysis with a pinch of salt because the study was not powered for them, and I'm not sure whether we have any robust comparison between Pola RCHP versus D-APOC-R. So I think a cross-trial comparison between the studies might come with its own limitations. So unless until we have that, I think in younger patients, comparing the two regimens, I think that is quite logistics dependent, and it might not be like write off DAPOC-R in that setting. Second thing is, like, again, what we have seen is that most of the double hit lymphomas, they are GCB subtype, many of them. So I think in that regard, because of superiority of Pola based regimens in ABC subtypes, I'm not sure how that fares well in that context.
Yeah, definitely. That is, these studies were not powered to actually check the that sort of a subset, but they are actually they're based on subset analysis. Maybe your point is well taken that we can't compare the two so groups in this study. So now I would like to know from Dr. Deepak about CNS prophylaxis. So how you actually use CNS prophylaxis in your patient of DLBCL, while there is a confirmed or there is a high suspicion of CNS involvement?
So, there are two scenarios when the CSF is negative or positive, right? In the prophylaxis scenario, where the high risk of CNS prophylaxis, lapse is there. I give intrathecal methotrexate with along with the every cycle of chemoimmunotherapy, whatever the cycle, whether it's the RCHOP or whether it's a pola-based regimen. But in few cases, in young patient and this high K67 and the CMYC positivity, so we consider as a 3 to 4 cycle of high dose methotrexate as well.
So you give it as a sort of day 15 based therapy?
Yes, day 15 after completion of 6 cycles of chemoimmunotherapy.
Okay. So I think, as the panelists rightly pointed out, that we have a lot of controversies how to best define and treat the high-risk patients. We have many regimens that are available, which include the all-CHOP, the dose-adjusted R-epoch, and the pola-R-CHIP. And these are the various trials what they have tried. Again, as was mentioned by the panelists, one of the Dr. Hussain was mentioning about the Kodak-SAM IVAC as well. So many of those things have been trialed, but unfortunately, to the time, it has shown no improvement in PFS, OS, or the response rates. Although dose-adjusted ORIPOC has been tried and it has been seen, but as was said by Dr. Aditya, that of late, the studies have not shown much of this benefit as far as the various endpoints are concerned. POLARIX trial was one of the studies where, based on the subgroup analysis, if we see the double expressor and the double hit lymphoma, high-grade B-cell lymphomas, there was a benefit. I think we can consider this sort of a regimen, but again, this is a subgroup analysis. We should take it with caution because we know that the number of patients were not high, and we still don't have much of a sort of data for that from the long term. So if the long-term data comes up with this study, as far as the subgroup is concerned, we will be a little bit more confident in using this sort of a regimen in this subset. Now, coming to the another scenario that we see in our patient is about the elderly population. Often we see that DLBCL patient, they tend to be elderly. We have one of the case scenarios I will be discussing, though this is a patient of 70-year-old male who was presented with a right-sided swelling and discomfort, mild dysphagia, and unusual snoring. On examination, there was a enlarged, firm, non-tender right tonsil with a palpable cervical nodes. PET-CT showed hypermetabolic mass of 5 by 2 centimeter in the right palatine tonsil with hypermetabolic right submandibular lymph node. Biopsy confirmed it is a diffuse infiltration of large B cells with GCB type. FISH was negative, stage 2, IP of 3. So again, the clinical challenges that we face is about the high prevalence of disease comorbidities and the cardiac events in these patients. And we have to strike a balance between the efficacy and the tolerance. So I would like to know from my panelist again, Dr. Nitish, I would like to start with how you risk stratify this patient as low, intermediate, and high. And do you routinely perform comprehensive geriatric assessment, which will help your treatment choices in such patients? Dr. Nitish?
Definitely, I think geriatric assessment is very important in this scenario. And on top of that, age-related IPI becomes a idea where we can risk stratify these patients based on the staging. Again, basically, it is going to remove the age more than 60 subset. Otherwise, then it will be the same. And definitely, comorbidities at the age of 71 will play a great factor.
Yeah. So, Dr. Arun, I would like to know from you about the preferred treatment regimen in your older patients, how you treat these patients. As Dr. Nitish pointed that we have to do the comprehensive geriatric assessment. So what is your sort of regimen in these patients?
Use Minichop and bendamustine based regimes. These are the two I use in my routine clinical practice. If they are too fragile, I use Minichop. If they are okay with me, that means ECOG PS1 or 2, then based on that, what to say, based on the comorbidity, I go with the bendamustine. If the fit and if I feel fit enough, bendamustine, rituximab, or otherwise, uh, age-old Armonichap is the best for me. I totally use
So you
these
are
two
using
regimes only.
bendamustine based regimens.
Yeah, I use that.
And any use of mini or chop or yeah.
Many actually also, both I'm using, sir.
Okay.
Sir, sorry to interrupt. Just wanted to request you in conclude in next 2 minutes.
Yeah, but I'm just finishing in a couple of minutes. So,
May I,
Dr.
yeah.
Avadit, your take, how
So
you
I
choose your patients in the elderly population.
in the index case, the 3 points that I would like to highlight is that first thing is like in the Polarix, the age inclusion was up to the age of 80 years, if I'm right. So it included the elderly patients, and the outcomes in the elderly patients were actually better in the subgroup analysis. The 2 points that I feel intrigued and I do not have an answer about is that this patient has GCB subtype. Okay, and if I use Polarix based therapy in the front line, I'm not sure how to justify that, given the fact that our job is an equally effective and less toxic regimen. The second thing, and if I'm using Polarix in the front line, and then I do not leave it as an option in the subsequent lines if that's possible for this case. The second question that comes to my mind, and again do not have an answer, and I would like to request Roche to give an answer to me. In the second line, we are going to see glofitamab based therapies. So if we are not using polatuzumab in the front line, then where will be Polarix-based therapy in the subsequent lines, especially in the GCB subtypes? Is it going to be obsolete in the presence of glofitamab, or would it still be a relevant option? So I think these are the two questions that I'm unable to figure out right now.
Yeah, I think your points are well taken, especially in this set of a setting where you are treating with the elderly population with the GCB based subset. So anyway, I think some of the things will be there. So
Dr.
overall,
Burhan,
I think over a period, yeah.
Yeah. So this case, there is a good discussion. So he's a stage 2 disease with a
Yeah,
good
he is a
PS.
stage 2 disease.
Stage 2 good PS. So though IPI was on higher side, so why not to give, though he's a GCB type? I asked this question to one of a prominent person one day that we have say what Dr. Aditya is telling, that are we ethically or morally correct that offering Pola RCH? But he was telling that whatever they do in US, this has come in the guidelines. This has been approved by FDA for NHL. DLBCL. So there is no difference that whether you have a ABCR GCB type. So this is what he was his experience that we offer to every patient, whether it is GCBR, it is though it has shown better results in ABC, but Dr. Aditya has pointed out. So this case, if we have a good PS 0, so why would not to give him Pola RCHP four cycles, 6 cycles, and then leave him. Otherwise, in
Yeah, I think
this higher
only thing
age,
in
I
yeah,
think
here.
one of the panelists, Dr. Arun, I think I will disagree giving BR upfront. I don't think there is some
Yeah, I think
enough
most of the
data.
times we have
Otherwise, R mini chop is commonly used in elderly patients who have PSR, some comorbidities.
Sir,
only
request you to
thing.
conclude your presentation.
Yeah, I think.
Can I have a comment, sir?
Yeah, Datish.
The issue with the GCB type is when we do a genetic assessment, we tend to find that it is a heterogeneous group again, and some of those patients who have a GCB type, there may be falling into a high risk category once the genomic profiling has been done. So till the time we don't have the genomic profiling coming up in the clinical setting, we will be having this doubt, do we use POLA in the GCD subset or not? But definitely, if we use, we are not wrong.
So I think there are a number of factors that come into play, especially what I feel in this particular patient. If we are seeing the IPI is high, we are still, even being the stage being 2, we can still consider the polar archive. So thank you all for panelists for this discussion, wonderful discussion. I would like to thank the Roche for the sponsoring this event. So I will hand over back my
Thank
to
you.
the organizers. Thank you very much, Mukesh, for the giving us the opportunity. Thank you very much.
Thank you, Dr. Burhan, and all the panelists for the wonderful discussion. I will
So,
like
Dr.
to
Mukesh, I
learn.
have a question if I can ask.
I will like to learn from any of you having any experience of using Carticel or glofitamab, as Dr. Aditya mentioned, in relapsed DLBCL. Have you people started
Experience.
using Carticel?
No,
Glofitamab is
we
good.
don't use.
You can
Yeah,
use
Dr.
glofitamab.
Aditya, I think
Yeah, Dr. Aditya, please go ahead.
So we at PGI had the opportunity of using CAR T cell as a part of clinical trial in one of the mantle cell lymphoma, and he did well initially, but relapsed at day 100. Recently, we have given commercial CAR T to one of the DLBCL patients, patient primary refractory on R-CHOP. So he is doing well in CR at day 100.
Okay, thank you.
So, Dr. Mukesh, I have a question to ask.
Yeah, sure. Go ahead.
So I just want to know, so how do you go about elderly patient with low ejection fraction? What is the safety of polatuzumab? Has anyone used polatuzumab in such patients with low ejection fraction of around 20-30%?
I think there is no safety concern for cardiac patients, but we have to use a regime where we don't give anthracyclines in such scenarios because ejection fraction is what you are saying around 30%. So we have to avoid anthracyclines. We can choose a non-anthracycline where we can replace Adria with etoposide, gemcitabine. We have treated recently a patient who had an ejection fraction of 30%. We gave him our mini C GVP where we replaced Adria with gemcitabine. So there's a good evidence of using etoposide, gemcitabine, and even we can use lipodox that has some better cardiac safety compared to the conventional adriamycin.
So what about using polatuzumab and rituximab in such patients like POLARIX?
But probably there was not much safety concern for this. So there is some known cardiac toxicity in patients who have underlying DCM with rituximab, but I'm not aware about the polatuzumab.
Okay. Thank you.
Thank you, Dr. Burhan and all the panelists. So, moving on to the next session, actually the last session of the two-day event. I request my dear friend, Dr. Aditya Sareen, Consultant, Department of Medical Oncology, Cancer Genomics and Precision Oncology, Sir Gangaram Hospital, Delhi. He will be discussing on the clinical insights and ASCO updates in genitourinary cancers. Over to you, Dr. Aditya. Welcome.
Yeah. Hi, and good evening, everyone. So you guys must be having my slide deck, and can I have it? Mukesh, can you invite my panelist, as
Yeah,
always?
sure. So, welcome Dr. Navdeep Singh, Consultant Medical Oncology, AOI Jalandhar. Dr. Chandrasekhar Prasad Singh, Consultant Medical Oncology and Hematology, SCG Hospital, Ranchi. Dr. Neha Gupta, Consultant Medical Oncology, Max Hospital, Bathinda. Dr. Rajit Ratan, Consultant Medical Oncology and Hemato-Oncology, Medanta Hospital, Gurgaon.
So do we have everybody here?
Yeah, I think we have the full.
Yes, Dr. Rajat is here. I can see Neha. Navdeep कहाँ गया? Navdeep नहीं दिख रहा.
Dr. Navdeep?
हाँ हूँ मैं भाई.
तुम दिख नहीं रहे ना, छुपे हुए हो तुम
मैं
कैमरे के पीछे.
दिखूंगा नहीं अभी, मैं बोलूंगा.
अच्छा, तुम दिखोगे नहीं. देख रहे हो मुकेश, तुम्हारी कॉन्फ्रेंस में दिख नहीं रहे लोग. बात करो.
भाई ने
ओके.
संभाल था, अब जरूरत थी. हमारा
भाई
बंदा
ओपीडी बैठा है. भाई
बंदा
ओपीडी
भाग गया
बैठ
था,
के
भाई ने
पेशेंट.
संभाल लिया लास्ट मोमेंट पे. मैं नहीं कुछ कह सकता इसको आज.
Chalo. Okay. So we'll be diving into the discussion. So Dr. Ajit, starting with you. Welcome back to Delhi NCR.
Thank you. Thank you.
And so how many patients of bladder cancer and what is your experience in your practice?
Since I've come from a place where I didn't see much patients, to the new place where there are plenty of bladder cancer patients, I've had the privilege of treating, I think, about 5 cases till now, muscle invasive localized bladder cancers. And
Okay. And how lucky are you in terms of the urologist? Do they send you such patients?
that's always been a concern, that urologists always try to find reasons to go for upfront surgeries. And why I consider myself lucky is that those 5 patients actually refused upfront surgeries because of the concerns and the problems associated with it. And then the patient was finally referred to me. I've
Okay.
yeah, I've used neoadjuvant therapies in those patients.
Agreed. So Dr. Chandrasekhar?
Yeah, hi, good evening, Dr. Aditya.
Hi, good evening.
So
Your
I'm
experience?
yes, I am treating few patients of muscle invasive bladder cancer, and I have 2 to 3 patients on perioperative Durva plus Gemcis.
Good. And how are your urologist friends over there? Are they courteous enough to send you upfront, or the same problem that Dr. Ajit is facing, you are also facing the same?
This is, I think, universal, particularly
Universal.
talk about this part of country. Then they try to go for upfront surgery, but yes, nowadays awareness is there, and we get a lot of patients for neoadjuvant.
So in the end, I'll share one story.
Can I interrupt? I have a
Yeah,
question for
yes,
Dr.
Mukesh.
Chandrasekhar. You are using this Niagara trial regime, na? Durva plus Gemcis
Yes. I have
neoadjuvant setting.
currently I have 2 patients on this regimen.
Okay, so you are not having any issue with the approvals, because I think recently I inquired for a patient, and I was informed that it is not still DCGI approved. And
So PAP is not there. The drug is available. Irrespective, you can give the drug.
but we
So
don't
I
have
have
rich
I
patients
have
like you, Dr. Aditya. We have to survive on CHS and CGHS,
Exactly.
and we have to look on that part also.
So then that's your problem, boss. I have only cash and TPI. I don't have any CGHS or any TPI. Baba re Baba.
So
वो
Dr. Chandrasekhar,
Max को छोड़ के
I
आया
think
था
Dr.
भाई.
Chandrasekhar is also like us. So I will like to listen from him.
Yes, I have 2 patients of cold fields, and the doctors referring to us, they are not aware of oncological practices, so then they don't create so much problem for us, and
Good.
they usually allow whatever we prescribe.
Great. Please go ahead.
Dr. Navdeep? Where is he?
Manjeet,
Dr. Navdeep?
Yeah.
Your thoughts?
See, if the patient comes to me and diagnosed as a muscle invasive bladder cancer, then I go for neoadjuvant chemotherapy. Yes, there is a issue of same with us also, but yeah, wherever you can, I use NSCT.
Okay.
Yeah.
And now after looking, so you must have gone through Niagara trial. Though Dr. Neha, I would like you to jump in now. Is it a practice changing trial good enough for you, or you want something more?
So it can be practice changing, but sitting in a two-tier city where the patient are very reluctant to get surgery done, they are very surgery reluctant patients, and they don't want to get a surgery. They only want to get chemo or CTRT at the max. So this trial is little contradictory for me at sitting at this place, basically.
Okay. So we'll be dissecting the trial now. Okay, so this was the additional efficacy and safety outcomes and exploratory analysis of the impact of PAT-CR on long-term outcomes from Niagara trial, presented at ESCO. So next slide. Okay, so I'll take first Dr. Chandrasekhar's opinion. So Dr. Chandrasekhar, your thoughts
Yeah,
on
so
the EFS?
whenever we talk about any treatment which is of curative intent, then particularly in neoadjuvant setting, then pathological CR is a sort of surrogate markers, what we
Yeah.
have experienced in breast cancer. So I think this data is good enough to incorporate immune checkpoint inhibitors, and we should definitely offer it to our patients.
So I think it is very well clear from the graph that the curves are separating well on 1 or 2 months in the journey of the patient, and they kept on separating till the end. you have a benefit of approximately 10% improvement in the PAT-CR rates with both the hazards, whether the EFS or whether the OS, both are significant. And this is one of those classical, immunotherapy kind of a Kaplan-Meier graph. At the end of the day, I want to see a graph. It's like a lorlatinib. You can fit a truck between the two lines. But here, it's classical those immunotherapy curve where they keep on separating slowly, slowly, slowly. And then the final analysis, if you see at the end of 2 years, it is 67.8% versus 59.8% PFS benefit. So again, a benefit of 10%. Next slide. So, Dr. Rajat, your thoughts on the trial schema? Are you comfortable with the 4 cycles, or you think that better to give it 6 cycles, or any modification in the protocol, or as per our Indian requirements?
I think GEMSIS for 4 cycles is pretty much an adequate regime. Stretching it to 6 cycles doesn't actually benefit as has been seen in previous trials. So I'm okay with it.
Right. And next slide. So my slides are pretty much very simple, basic. So there is no confusion, and we'll be sticking to the point. I think go to the previous slide. Yes. So Dr. Neha, your thoughts on the slide?
So we can see pretty much broader curves at the end, and now we can see a good PCR rates with durvalumab plus GEMSIS. So we can go for a thought change in this particular trial.
And here you can see that the MFS is to the tunes of 10% again. And how good is this kind of a parameter, metastasis-free survival? Dr. Nadeep?
Yes.
Would you like to see a trial where metastasis-free survival is one of the endpoints? Or you are still comfortable with the EFS?
So I think EFS, I am very comfortable. So in such kind of patient, we don't know what is the outcome and how we should quantify it, whether the what quality of life and all the parameters. So still, I'm okay with the there is event-free survival.
Okay, next slide. Here we have disease-specific survival. Dr. Chandrasekhar, again, so we are just talking pure statistics. It's one of my weakest subject. When we are talking disease-specific survival, what does it really means?
So look, in this part of country, what socioeconomic status of patients I treat particularly. So my primary goal should be to improve overall survival in any malignancy, to be it cost effective. But yes, when we discuss about a specific disease-free survival, then patients have a lot of comorbid conditions as well, and few patients die with disease rather than due to the disease. Particularly if you talk about prostate cancer. So I think yes, it can be an endpoint, but to be cost effective, it should be at least invasive disease-free survival.
Dr. Rajat, is DFS is equal to DSS, or are they both different?
Yes, I think they are different. Would mean disease-free survival, or that means how long how long a period that the patients are without a disease. A disease-specific survival will include only the survival which is in patients who do not recur. It does it excludes the patient who die of various comorbidities or various side effects of therapies. So two of them are different and
right. So I think it is from the date of randomization till the death due to bladder cancer. That is your disease-specific survival. Okay, so again, you are still seeing a good, I think 5-8% of benefit over here, and the median has still not reached in both the arms. So next slide. So now the pathological CR rates, if we were to compare, Dr. Neha, let's say if cost is not an issue, you are comfortable as PAT-CR being the surrogate marker for an OS benefit?
So
Or your thought process towards MPR is also there now? Now we have new term which is MPR.
So if we can extrapolate to the breast cancer data in TNBC also, we have seen that if good PCR is there and there is more good survival chances. Similarly, if we can see in this particular trial also, if there are good PCR rates, we can expect a good overall survival in this arm as well. But yes, it is very earlier to say because we need much more time and results.
Okay, next slide. So this was the comparison between the patients who had PAT-CR versus patient who didn't have any PAT-CR. So you can see a good, I think both the arms were well matched. So we'll just skip to the next slide. So this is very important now. So if a patient of yours is having a PAT-CR with this kind of a perioperative approach, it's 92% chance of having a good percent of DFS. And if your patient is not having a PAT-CR, I think that gives you the answer. So are we really, what do we expect when we start? Is there any way to beforehand to know which kind of patients are going to land up with the PAT-CR and which kind of patients are going to land up with non-PAT-CR? Dr. Navdeep, any way to predict where my patient is going to land if I'm any high risk factor or any feature which can predict this particular outcome before we start?
I think most of the time we should be looking for a biomarker if you want to some biomarker which can help in the prediction. So like we do in patient when we give immunotherapy to check PD-L1 status and all the things on. So I think a relevant biomarker could tell us in which patients this PAT-CR or maybe some high risk factor. But we
Right.
need a
So
specific
now
biomarker.
see, most of the trials are not being done as a biomarker based done. It's always in the subgroup analysis. And more or less, I'm thinking that we need to go beyond the discussion of biomarkers and we can think about, proteomics or microbiome or metabolomics. So Dr. Ajit, is there any way to predict an improvement in the immunotherapy response with any of the modalities like proteomics, metabolomics, or anything that you can add to the discussion?
One I know is that people have tried to use radiomics in this. In UK, they've been doing some texture analysis to see which patients will respond well to therapy, neoadjuvant, and then they haven't fully used it in their sort of daily methods. It's still in trial basis, and I don't think we have anything as to show for clinically that that can predict a good response to therapy or not.
Absolutely. I mean, if you were to see, renal cell carcinoma, clear cell, they all do well irrespective of your markers. Even if your patient is having an PD-L1 in the subgroup analysis of the keynote, so number I don't remember, but at the end of that subgroup analysis did show that irrespective of your status of PD-L1, your patients are going to do well. You see another trial from, rectal cancer trials, the NICE-2 trial. Everybody is doing well if you are sure that your patient is having a DMMR. So I think we are just a step behind to know what exactly differentiates such patients from PAT-CR versus non-PAT-CR. And here the another point I want to highlight, they are showing that 85.8% at the end of 24 months in the comparator arm on chemo had PAT-CR. Mind it. So I will go to Dr. Neha. I agree to your point that most of the times your patients are going to go with the chemotherapy. Is this really the practice? Do you see such high PAT-CR rates in your practice?
Not much, sir.
I think this is the probability of event-free survival at 2 years. The rates of PAT-CR were in the previous slides. I think it was somewhere around.
So we have shown two curves. The upper curve is for patients who have undergone the PAT-CR, and the second curve is for non-PAT-CR. It's there. And Dr. Chandrasekhar, your thoughts?
So PAT-CR rate are in the tune of 20 to 30% only. If patient is cisplatin eligible, then you can get a PAT-CR rate of around 20 to 25%. And adding immunotherapy can boost PAT-CR rates. but it is not that high, 80%.
Not that high. So I think the upper curve is very less, maybe around 5-10% of the patient of all the practice. So in any way, they are going to get benefit. But most of our patients, if we look at the numbers, you just see on the non-PATS here, it is 334, and in the CR arm, it is 199 patients. So obviously, most of our patients are going to land up in the non-PATS CR. So we have to find that 1:3 kind of a ratio where the third patient might get a benefit with this kind of a regime. Next slide. So this is the OS. Somebody was talking about OS. And Navdeep, you take this OS reports in the PATS CR and the non-PATS CR. Are you comfortable choosing this molecule as it is showing a PATS CR OS improvement now? Again, it's a significant one.
If you go with the all the hazards, and you might choose, but I personally feel it doesn't much add advantage in OS.
सर मेरे को मेरे पेशेंट के लिए 2% का भी बेनिफिट हो हम तो देना चाहेंगे अगर ऐसा कोई पेशेंट आया फिर तो कर सकते हैं ना फिर तो कोई रोकेगा नहीं जैसे अभी पोलर एक्स में डिस्कस हो रहा था फॉर स्टेज 2 आई एम नॉट श्योर whether to give polatuzumab in stage 2 lymphoma or not, even though we have the approval.
So,
but we don't use Pola in stage 2. I think
I am
none
not
of us is
Pola
using
yet, so I can't comment. So you might can comment on it. But yes, the data is good there. The pathology PCR definitely we're seeing we're getting converted to overall survival. But I think if the patient can afford and we have availability of drug, we should use.
Okay. So next slide. So I think we can just skip it. Next slide. So there was no new major adverse event, only the immunotherapy related events that we all know how to manage. I'm not going to into discussion to that. Next slide. So this was the final analysis. It showed a clinically significant and statistically meaningful EFS benefit with the risk of a metastasis-free survival was reduced by 33% and the risk of disease-specific survival was reduced by 31%. And perioperative Durva with the chemo improves EFS, OS in both PATS-CR and non-PATS-CR group. So it is one of the groundbreaking practice-changing trial that has been published in the ASCO 2025 GU update as per the 2-year data set. When it was presented last year, again, the questions were there, but again, still the benefit is still there. And I think things are going in the right way. So next slide.
So are you using this particular trial in your settings?
Yeah, I am doing it.
Okay. How the response gone?
So I'm Yeah, so this is another trial, another very interesting concept. SURE-02 trial, a neoadjuvant sacituzumab govitecan with pembro followed by a response-adapted bladder-sparing and adjuvant pembrolizumab in patient with MIBC. And now the confusion worsens. So next slide. So the combination we all know, sacituzumab and pembro, fantastic results. OS benefit of 35 or 36 odd months. Any debate over here? Anybody wants to comment on sacituzumab and pembrolizumab? Cost is not an issue, mind it. Dr. Ajit, given any patient coming with metastatic disease upfront, are you comfortable with the combination?
I haven't given SG, so I don't know how it will be tolerated. But again, as you said, fantastic results.
So I have seen the results with enfortumab along with pembro. I mean, they are fantastic in metastatic setting. And again, sacituzumab will just go through it, and I might be able to convince you that this is also one of the good combinations. And okay, so perioperative combination of single agent ADC was safe and resulted in 44% CR, allowing a bladder saving approach. And distinct biomarker features linked to SGP benefits are emerging, point to luminal subtypes and IO-related features. So we'll just dive into it. Next slide. So we all know about the prognosis of MIBC or ineligible to receive the cisplatin-based chemo. It all remains poor. And for these patients, upfront surgery or CTRT is standard of care. So the first trial was PURE-01, where a PAT-CR of 42% done at pembrolizumab monotherapy with the median follow-up of 5 years. And then SURE-01 trial was of sacituzumab, where there was a PAT-CR of 36.4%. Then increasing concerns about the combination therapy to achieve the complete response, and therefore SURE-02 was designed where they have taken pembro and sacituzumab. Next slide. So here you give 4 cycles, and you can then plan if a patient is improving for the radical cystectomy or re-TURBT, and then you can keep the patient on adjuvant or maintenance pembrolizumab for 13 cycles. And I think the characteristic are one of those classical T2, T3B, MIBC with urothelial histology, ineligible or using a neoadjuvant chemo, refusing CTRT. So these criteria should be met. So patient doesn't want radiation, patient is not fit for chemo. There you can have a completely targeted and immunotherapy based approach. And I think the primary endpoint here being this here. Again, mind it, it's a phase 2. Next slide. Next slide. So here, I think what is the demographic of the patient look like? So only 36 patients were there with the median age of 60, 22% were female, and smokers were mostly current smokers. And ineligible were 36%, and refusing population was 64%. So age group is from 61 to 71 years old. And tumor stage we all know, so we can just move on to the next slide. So what about the adverse event in the SURE-02 trial? You can just see there was no clear association with UGT1A1 polymorphism because the antibody drug conjugate belongs to the irinotecan group, I think. And that's why they have to mention it over here. Coming on to the treatment-related adverse event, there were immune-related were 46%, and the treatment-related were 97%. So somebody had something or other thing in terms of constipation, nausea, vomiting, AST, ALT, elevation, hyperglycemia, diarrhea, thrombocytopenia, and anemia. Coming on to the immune side effects, I think it is thyroid dysfunction, rash, arthritis, and xerostomia. So these are all common, routinely seen side effects of immuno. Trodelvy, I have not used that much, but I'm hoping to use it in breast as well. I have not used Trodelvy. Next slide. So this was the interim analysis of the trial where out of you all know that there is only 36 patients and 16 patients had complete clinical response. That is to the tunes of 44.4%, and 55.5% had YPT less than N1, N0. Dr. Ajit, Dr. Chandrasekhar, let's go to you. Your thoughts.
Yeah, so I don't have any hands-on experience of this drug in MIBC, but yeah, this data is encouraging and looks promising.
And how is your experience with Trodelvy in such in general? How do they tolerate Trodelvy? Have you used Trodelvy?
I don't have any hands-on experience, even in breast also.
Anybody has any experience with this drug, SG, sacituzumab? Navdeep, Neha, Dr. Ajit, anybody?
Dr. Ditta has.
Okay.
He can share
So
his
next slide.
views.
No, I have not used it. I have advised to few of my patients, so my learning curve is not reached. I'm like you guys. Next slide. I have no idea about this drug. Well, enfortumab I have used, but that's a completely different ball game. You have to be thoroughly, motivated to know every patient's side effect. Enfortumab is a very tricky drug. So, any thoughts about enfortumab, Dr. Ajit, Dr. Chandrasekhar?
Again, I haven't used.
Okay. Enfortumab is I think because these ADCs, you can land up with a lot of trouble with them because you are combining ADC along with IO combination most of the time now. So the side effect you are experiencing in ADC with IO is I had a patient with flaring of cytokine release syndrome, and it happened within 4 days of administration of the dual combination of ADC and IO. Patient was about to die. I had to bombard him with a good amount of steroid. I had to do plasma pheresis, and that's how I was able to save it. Then again, re-challenge it with a single agent ADC. And it started with a very bad rash throughout the body, looking like a Stevenson Johnson syndrome. So very dangerous drug. So you be always on the lower side to start these ADCs. Never been a rush to start with the dot doses like we use in trastuzumab or Enhertu some does. I even don't do it Enhertu.
I think here again, if you see, there are 18% grade 3, grade 4 reactions. I think one
Yeah.
out of 5 patients will land up with admissions
Right.
because of therapy-related side effects.
So you can just see the swimmers plot over here. The 12-month EFS is 71%, 12-month MFS is again 84.2%, with the 12-month bladder intact EFS in CCR patients is 100%. All those patients are still living and they're doing well. And 12-month bladder intact EFS in re-TURBT patient is to the tune of 74%. I mean, this is another era of immunotherapy in combination with the ADC. So we are used to seeing curves with ADC alone or immuno with chemo, where you can just hardly fit a pen in between the two curves. Here, you see 100% MFS. It's something phenomenal. So I think we are another 5 years. यही सब combinations हम discuss कर रहे होंगे, which is better than the another one. Okay, next slide. So they have done the landscape genomic alteration, and they were able to found patients with CCR was having a 40% of ERBB2 mutation, then CDKN2 in 20%, and MTAP in 13%. And in non-CR, there was a high preponderance of CDKN2A 50%, CDKN2B 39%, MTAP 33%, ERBB 11%. I think we are definitely going to go into a completely personalized era. We'll be requiring AI search engines to have, give us the answer if you have such kind of a mutational profile. And baseline NGS, maybe 10 years down the lane, will become a standard of care. You will have to do a baseline NGS. Next slide. So the good thing about secukinumab is the TROP2 gene, and the earlier trials have shown that patients with higher gene expression of TROP2 mRNA, they tend to do better with this particular drug. And that is how this drug can help you if you have a TROP2 kind of a mRNA expression, then you know this drug is going to do better. So again, I think molecular subtyping reveals high CCR rates for luminal subtypes, immune activity, and mismatch repair signatures, and gene expression in terms of TROP2 or mismatch repair KEG and LUND. I think they are all doing better. And coming on to the variants by subtype show, luminal tumors have higher TROP2 expression, MMR activity, and ERBB2 expression. So this is new terminology for me to go to the transcriptosome level. Obviously, maybe anybody can give me a better answer so they can comment on this slide. Otherwise, I'll move on to the next slide. Okay, next slide. So conclusion that this combination has led to a compelling clinical CR rate to the tunes of 44%, allowing a bladder preservation without CTRT in 74% of the patients refusing the surgery. So this SHORE-02 trial provided a safe and effective approach, and luminal subtype recapitulated features associated with the SG response. So here SG, it can do better. Now let me just move on to the last slide. I will take another 2 minutes. Next. So this is Keynote 564, the result of the phase 3 adjuvant pembrolizumab treatment with the clear cell RCC, very kindergarten. Next slide. It is just a 5-year update. Next slide. Next slide. We'll go to the curve straight away. Next slide. Just that's it. No, go back. Yes, this. Go back. Yes, DFS. So Dr. Ajit, very short and crisp. all patients of high risk clear cell stage 2 and all patients with stage 3 adjuvant immuno? No questions asked?
No questions asked, yes.
Dr. Neha?
Yes, sir.
So how many of your patients are currently on adjuvant immuno?
Only 2.
Only 2. No, that's a good number. Dr. Chandrasekhar?
Yes, definitely we should offer. And currently I have only one patient on adjuvant.
So till 5 years, the graphs are still separating and the benefit is to the tunes of again 10%. Dr. Navdeep, anything you want to add at 5 years?
I think but I am using in any 2 and 3 high risk patient. Problem I faced in 2 patients with having rhabdoid differentiation. And what to go in the advanced setting? How will you go with these patients with rhabdoid differentiation?
So that's why I was about to come to my next slide. Next slide. Yes. So again, boiling down to those sarcomatoid or patients where your question is that you can see that it is just before the line of unity with the hazards of 0.56. And if sarcomatoid features are not there, again, it is benefiting, but it is hazards are better for patients with sarcomatoid feature as well.
In the
Now,
metastatic setting, the combination of
Dr. Navdeep.
Yeah, I'm just in
This
the
is adjuvant.
metastatic.
This is adjuvant right now. This is
No,
adjuvant.
I know, but I am saying in the metastatic setting, we prefer combining EP plus this called dual checkpoint
Nivo.
inhibitor in
Nivo and
sarcomatoid.
Ipi if you have a sarcomatoid differentiation,
Yeah,
correct? Yeah, that is for metastatic. That's
yeah,
done.
that's what I'm saying. But yes, maybe in near coming future we might have the combination in advanced setting also.
Let's hope. So next slide. So again, there has been a good amount of OS benefit, again, just like any immunotherapy trial, and the benefit at the end of 5 years is 7-8%. So yeah, better to give rather than miss out on the chance. Next slide, with the hazards of 0.66. And again, now OS benefit, Dr. Navdeep. Here you can challenge me. You want to treat 23 patients with something else here. You don't want to give immunotherapy here, if I'm not wrong. You want to give a different immuno.
Yeah, definitely there is a space which can be worked in such patients. Let's see what the data next come.
So if a patient with clear cell is there, in now coming on to the metastatic, I think you can just close my slides now. It's a very general discussion. So metastatic clear cell RCC, your go-to-go regime in the frontline setting.
I go with PK plus pembrolizumab right now.
Okay. And any special reference why Pembro and not Nivo? You have an answer of Nivo Cabo and you have an answer of Pembro with any TKI. Anything that sticks you to your mind that, these patients are going to do better with the Nivo? BMS people keep on banging your head. Doc, why are you not using Nivo Cabo upfront, clear cell? Dr. Ajit, your take?
I think Nivo Cabo is very simple to use, provided you obviously dose reduce your cabozantinib. But I think the advantage of using Pembro Axi or Pembro Lenva is that you can use Cabo as second line, which is a little reassuring to us that we have something left in the second line as well. That's probably the only reason I would use Pembro upfront.
Dr. Chandrasekhar, out of Nivo Cabo, Pembro XZ and Pembro Lenvatinib, which of the trial has the maximum amount of PFS benefit?
Yeah, so in my clinical experience, I think this might be very subjective experience. So axitinib is relatively tolerated better as compared to cabozantinib. If you are using full dose cabo, then it is difficult for patients to tolerate. So Pembro XZ seems to be more friendly to our patients, and I think yes, we have excellent data for Nivo EP as well, dual checkpoint inhibitors. So that is another option.
So I look at this in a way that if a patient is having any sarcomatoid differentiation, I would like to offer them upfront Nivo EP. And if finances are not an issue, then I would like to give an obviously patient without any sarcomatoid differentiation with Pembro and Lenvatinib, because your clear data set has the maximum amount of benefit in the cross trial comparison. And if the patient is able to afford the original Lenvatinib from the SI molecule, then my go-to-go molecule becomes lenvatinib original SI. Other than that, I am happy with the Pembro XZ and Nivo Cabo. Keep it reserved for non-clear cell or Cabo alone, maybe in the second line, and I think we all are in sync over here. So with this, I just conclude my discussion, and thanks to wonderful panelists. Dr. Neha,
Yes,
you have
sir.
been quiet. So anything you want to add to the discussion?
No, so that's all. Thank you so much.
चलो ठीक है मुकेश.
Thank you, Dr. Aditya. It's always pleasure listening to you. I
Thank you,
hate
Dr.
to
Sreen.
interrupt you,
Thank you.
especially in your flow. Yeah, we were overshooting time, but I couldn't afford to interrupt you.
So that's why I keep
energy and the
always
flow
session
you
in the
have,
last.
the flow you have. So I went on. Thank you, Dr. Aditya, Dr. Chandrasekhar, Dr. Rajit Ratan, Dr. Navdeep, Dr.
Thank
Neha.
you.
For
Thank you, Dr. Mukesh. Thank you, Dr.
Thank you.
Sreen.
conference,
Good
very
night.
special.
Bye.
Thank you.
Bye,
Thank you.
sir. Bye. Good night.
Yeah, good night. Thank you. So, with this, I think we have come to the end of this two-day event, Onco-Vigyan, Science and AI in Oncology 2025. I will like to thank all the faculty members who have actively participated, all our pharma partners, our academic partners. Their contribution, their help made this conference possible and successful. I will like to thank the organizing and the technical support team, Horizon, Mr. Tarun Mathur, Mr. Dhruv, Mr. Savarangi, Mrs. Ekta Mathur, and each of you. I think it was a great learning experience in this two-day event, and I look forward next year for the third edition of our oncology updates with more exciting data and more exciting updates.
Sure,
Thank
sir.
you, everyone.
Thank you. Thank you, everyone. Good night, everyone.
Thank you, sir.
Thank you, sir. Thank you.